Okay, thank you so much, Dr. Khanna, for that wonderful review of the epidemiology, risk factors, and diagnostic considerations when it comes to C. diff in IBD. As we all know, that can be incredibly challenging to decipher exactly what's going on with our patients who have IBD and then get a diagnosis of C. diff. That process can be difficult. And so I think that was a really great overview. My name is Ari Grinspan, and I will be continuing on our discussion, specifically focusing on the treatments of C. diff. And so the objectives and outline of my talk today will be, again, we'll talk about the management of C. diff in IBD. Then we'll talk about the management of the underlying IBD, which can be very challenging. And then, of course, we'll address the elephant in the room, how to manage our patients with IBD who have C. diff in the setting of the COVID pandemic. So the ID Society of America published these guidelines a couple of years ago, and these are the latest and greatest treatment algorithm for patients who have C. diff. And what they did is they categorized the patients into those who have non-severe C. diff, severe C. diff, and fulminant C. diff. The definition of severe C. diff is a patient who has a white blood cell count greater than 15,000 or a creatinine greater than 1.5 that is attributed to the C. diff infection. Those who have fulminant C. diff are those who have hypotension, shock, or ileus. In terms of the treatment of C. diff, what you'll notice is that there's been sort of two major changes. Metronidazole is no longer a first-line option to treat our patients with C. diff. Fidaxomicin and vancomycin are the two first-line options here. And so when it comes to our patients who have a C. diff infection with underlying IBD, again, we should be treating them with vancomycin or fidaxomicin. The only use of metronidazole at this point in time is those who have fulminant C. diff infection, in which you would use metronidazole IV in combination with vancomycin by mouth and consideration of vancomycin enemas. Now, what's interesting in our particular patient population, those with IBD, is that there is a little bit of data suggesting that maybe we shouldn't just be using a 10-day course of vancomycin. This is a retrospective study that came out of the University of Chicago, where they looked back at their patients about those who got a standard dose of vancomycin, 10 to 14 days, or who got a longer duration of vancomycin, 21 to 42 days of vancomycin. And when they looked at the recurrence rates, so recurrence, again, as Dr. Khan had mentioned in his earlier talk, were those who have symptoms and a recurrent episode of C. diff within 8 weeks after the last dose of antibiotics. Those who got a longer duration of vancomycin had a significantly lower recurrence rate within that 8 weeks compared to those who had a standard dose of vancomycin. That difference disappeared after the 8-week mark. And so there was no significant change in those who got a longer duration or a standard duration of vancomycin after 8 weeks. The takeaway from here is that if you have a patient who's sort of in that transition period of biologics, or if they're not doing well and you're escalating their therapy in one way, shape, or form, and they get a C. diff infection, this may be the population that you would consider extending your course of vancomycin while you're getting their IBD under better control. When it comes to recurrent C. diff, as Dr. Khanna mentioned, this is a very bad problem that we have to deal with, unfortunately, all too regularly. And this is data that shows, 20% recur after a first treatment and 40% recur after a second treatment, and nearly 2/3 of patients will recur after a third treatment. What's interesting is that the data for IBD suggests that these rates may even be higher. And so prevention strategies is the most important thing that we need to talk about with our patients who develop C. diff. The classic prevention strategies involves reducing their need for antibiotics, narrow spectrum antibiotics if it's required, potentially discontinuing PPIs, which have been shown to have a slightly increased rate of recurrent C. diff, among other things that we typically talk to our patients about. But when it comes to pharmacotherapeutics, there's a new agent called bezlotuximab. This is a monoclonal antibody against toxin B. It's a single IV infusion that's given at the same time as a course of antibiotics. And it's been shown to have about a 10% absolute risk reduction in recurrent C. diff compared to those who got a placebo. So this is another agent that we could potentially use in our IBD patients to prevent that next episode of C. diff. In post hoc analysis from the Modify 1 and 2 trials, looking at the patients who were included in these studies who had IBD, there is a suggestion that they had even greater benefit than this 10% absolute risk reduction. That being said, more studies is needed so that we can further identify if this holds water. In terms of FMT, FMT has been shown over and over again to be the most effective treatment of recurrent C. diff. So yes, your patient should get better with a course of antibiotics, but performing an FMT via duodenal infusion, colonoscopy, enema, or even capsules, this has been shown to be the best way to prevent another episode of C. diff. This is for all comers. Now, what about specifically our patients with IBD? There's been a couple of retrospective studies trying to answer this question. And they've all made their definitions of cure rates, their definitions of complications that can occur after FMT in different ways. But of these three trials, they did show, or these three, retrospective studies, they did show that about 80 to 95, 97% of patients were cured of their C. diff. But the notable finding was that there was some significant reports of IBD flares after the FMT. Again, different definitions about what defined an IBD flare, so it's hard to understand exactly what was going on in this population. So our chair of today's program, Dr. Allegretti, she spearheaded the ICON study, which was just published in Gastroenterology earlier this year. And the purpose of this study was to see, okay, let's prospectively analyze these patients with IBD who also have C. diff, who undergo FMT, and let's see what actually happens to them. The primary endpoint of this study was failure of FMT at 8 weeks. And the failure was defined as symptoms of diarrhea and a positive C. diff toxin assay. So a very hard endpoint. And in terms of secondary endpoints, yes, we looked at IBD, adverse events, other things that could potentially happen with the microbiome and bile acids during an FMT for these patients. In terms of the results, FMT was shown to be remarkably effective for C. diff in patients with underlying IBD. So about 90% of patients were C. diff negative at week 8, which translates to a 10% failure rate in this population, which is what we see in the general population and similar to what we have seen in other studies as well. In terms of its effect on the underlying IBD, interestingly, only one patient out of the 49, so 4%, one patient, had a de novo IBD flare after the fecal transplant. And I think this was the hallmark for me of this study, which showed that yes, it's effective, but also FMT is safe in patients who have underlying IBD. So the FMT failures were actually lower than previously reported in some retrospective studies looking at FMT for patients with underlying IBD to treat their C. diff. Part of the reason is that in this ICON study, the patients who were enrolled, they weren't necessarily on their third, fourth, or fifth episode of C. diff. Patients were enrolled after a first recurrent episode. And so my take home is perhaps we should be using FMT a little bit earlier on in the algorithm for our patients with IBD. As Dr. Khanna so nicely went over, patients with IBD who get C. diff, bad things end up happening to them. So we really have to be, in my opinion, more aggressive with the treatment of C. diff to get their IBD, allow their IBD to get under better control. Again, few patients experience a de novo flare after the FMT, which bodes very well for our patients for future use. And in terms of some of these other endpoints, a microbiome endpoint and the bile acid endpoint, which the story of bile acids is fascinating. And Dr. Allegretti has done some really great work on this. But what we did show is that after a fecal transplant, there's improved diversity that is sustained through 12 weeks. And there are these lasting changes in the bile acid milieu in the patient's colons. And again, this is a very interesting study, but for another time, we can talk about bile acids. Okay, now, how do we actually manage the underlying IBD? So you have your patient diagnosed, you feel confident that the patient does have a C. diff infection. You start the patient on antibiotics. What do you watch for? What do you wait for? How do you decide that it's effective or not? Well, you're looking at their symptoms. You have to figure out, okay, does this patient continue to have active colitis symptoms after 3 to 4 days of appropriate antibiotic therapy? That's your decision point. That's when you have to sort of think, okay, is it just the C. diff that's triggering their symptoms, or is their underlying IBD active? Again, if you get to that day 3, day 4 mark on appropriate antibiotics and they continue to have active colitis symptoms, this is where you have to consider escalating their immunosuppression, starting steroids, starting a biologic, something, or changing a biologic, something to get the underlying IBD under control. This algorithm that was published by our colleague, Dr. Khanna, it should be individualized for your patient. There is no good data about exactly what you are supposed to do or what to expect in our patients. The data just isn't there. That being said, in terms of patients who have a C. diff infection, if you escalate their care, is this something that is safe? And so we do have some retrospective data suggesting that escalating care during or after a C. diff infection is safe. And so this data comes from a couple of centers in New York City, where they looked at their patients who had IBD and C. diff, and whether their IBD care was escalated, meaning did they start steroids, did they start a new biologic, or some other new medication. And if you look at the patients who did undergo escalation of care, either during or within 30 days after their C. diff infection, my takeaway is that we don't see bad things happening to them. We don't see death. We don't see sepsis. We don't see colectomy. And so that suggests that escalation of care is safe. Again, the individual care for your patient, you're going to have to make that decision based on a number of different factors. But I think the takeaway is that if you decide that you do want to escalate, that is indeed safe. Now, COVID, addressing the elephant in the room. We do know that COVID causes GI symptoms, and we have good data to show that at least 10, if not 20% of these patients, this study showed 12.5% of patients will report diarrhea along with their COVID. The question is that only from the COVID infection, or is there something else that's going underneath? And so we do have some data that suggests that there was no significant increase in nosocomial C. diff rates in patients who were admitted to the hospital with COVID. Now, it doesn't mean that we don't see C. diff. But again, if you think about these patients, these are sick patients. They have comorbidities. There are multiple antibiotics to treat the COVID. It's reassuring that we don't see an increase in C. diff rates in this population. That being said, diarrhea, again, it's very common. Don't forget to check the C. diff to make sure that you're not missing something else that's causing their symptoms. In terms of COVID's effect on the treatment options for C. diff, OpenBiome, which is essentially the national stool bank, this is where most providers get their FMT product, they are on temporarily clinical hold, meaning they're not distributing their product to providers to treat recurrent C. diff. Now, FMT can still be used under enforcement discretion, but most practitioners are deferring treatment at this time or reverting back to patient-directed donors to perform FMT. Dr. Khanna just published this very nice article a couple of months ago in the Red Journal, which spoke about this topic in particular. And the takeaway from here is if you have a patient who has non-fulminant C. diff, you start them on therapy and they get better, this is the time that we should perhaps extend the course of the vancomycin. Get them to the lowest effective dose. Get them to 1 tablet of vancomycin a day and continue that through the pandemic until we can reevaluate, reassess, and be able to treat them appropriately with consideration of a fecal transplant. In conclusion, initial C. diff, we should use vancomycin or fidaxomicin for our patients with IBD and C. diff. If they have recurrent C. diff, FMT is safe and effective. Bezlotuximab is another option that we can use for these patients. In terms of management of the IBD, If there's no improvement with appropriate antibiotics after 3 to 4 days, that's when you consider escalating an immunosuppression, starting steroids or starting another biologic. And in the age of COVID, we do have to modify our treatment plans for treatment of C. diff based on the availability of FMT and other resources. And so this is where we can use a prolonged course of antibiotic to treat the infection. Thank you so much for your time. And I believe we'll be moving on to a case-based session. We'll be talking about different cases that involve C. diff and IBD and some time for questions and answers. Thank you again for your time.